All right. Hopefully you all are seeing the correct screen now, and it's not giving screens within screens. I apologize for that. So thank you, Leslie, and we'll go ahead and get started with it. As she mentioned, my name is Bruce Mackey. I am the Regulatory and Incentive Program Analyst here at MCEDA, and I'll be talking to you today about the Meaningful Use Program and some of the changes that we've seen in 2013 and then additional changes in 2014 that just launched for us as well. So we'll be going over a brief overview of MCEDA. I know we have some folks on the line that are current clients of ours. There's a number of folks on the line that are not current clients, and so we'll go a little bit into kind of who we are and what we're doing here. We're going to give a very brief overview of the Meaningful Use Program for the same reason. We've got folks that are kind of just starting the program, might need a little bit of a refresher, and really just to kind of put the whole thing into context. I'll go over a few slides on the Meaningful Use Program in general, but not into any great depth during this broadcast. I want to spend the majority of my time discussing the actual changes to the in 2014 and some changes that happened in 2013. Those changes to Stage 1, and then we'll leave the door open for questions at the end. And I do want to note that during this broadcast, we are going to leave the lines muted. If you have any questions, please enter those in the chat box or the question box here in the interface. And at the end, we'll spend some time going through your questions. If I do not address the questions you pose to us during this broadcast, please note that I will be taking that offline. Sometimes the questions that are posed to us are not quick answers, or they're questions that we ourselves have to research and to ensure that we're giving accurate information. Sometimes questions posed to us are so complex that we need to go back to ONC or to MDCH at the state level and kind of ask for clarification or for answers from them. So if I do not get your question, please note that it will be addressed. After the broadcast within the next few days, I'll be putting together a question and answer digest that lists all of the questions and all the answers that were posed to us during this broadcast, and that will go out to all attendees. So just pose your questions, and we'll answer some of them at the end, hopefully all of them at the end, but if not, the rest of the answers will be forthcoming. All right, a little bit about MCEDA. We are the Michigan Center for Effective IT Adoption, so MCEDA stands for. We are one of the 62 ONC-funded regional extension centers providing technical assistance to providers across the country. We were founded as part of the American Recovery and Reinvestment Act back in 2009 to establish these 62 regional extension centers. And we're here to support the adoption of health information technology, HIT. We're here, our purpose is to build the awareness and accelerate the adoption, implementation, and effective use of EHRs. And we are the 8th largest regional extension center in the country, so we're one of the bigger ones, and we are providing services across the entire state. As you'll see in a slide or two here as well, kind of shows some of that information. So here I just wanted to share kind of our programs and how we're doing what we're doing. Back at the beginning of this, when our REC was established, when the whole REC program was established, we were initially only able to help primary care providers under that ONC funded grant. Essentially, the government was paying us to go out and help you guys achieve meaningful use. So that's the first bucket here for primary care. Last year, the state stepped up under the Medicaid program, and the Michigan Department of Community Health, MDCH, launched a funded program that allowed us to expand our services to specialists. And so we weren't relegated to just helping primary care. We could then step up and start helping specialists across the state as well. That said, we are definitely here to help any and all providers in the Meaningful Use Program. That third bucket there for a fee-for-service plan is really designed for anybody and everybody who does not fall under the two subsidized programs for primary care or for specialists. We're still here to help you. So please give us a call, and we can discuss kind of what the qualifications are for each of the subsidized programs. If we can't get you fit into one of those, we can discuss kind of what it means to be a fee-for-service provider under the MCEDA program as well. Our progress so far, we have over 4,000 providers that have enrolled for MCEDA support that have engaged with us over the past several years. The vast majority of them, more than 3,500 of these providers, are live on an EHR. Some of them came to us before they even signed up, and they were already on the EHR. That's another service we provide is we can assist you with implementing an EHR and kind of optimizing your workflow around your EHR. Over 2,100 of these providers have achieved meaningful use, and the rest, at least the vast majority of the rest, are well on their way to attaining meaningful use with our assistance, and we will get you there. The latest survey shows that the vast majority, nearly 100%, right, 96% of the MCEDA customers are satisfied with their services, and more than that, at a nationwide level, the U.S. government has surveyed groups and done their own research and found that practices that do sign up with one of the regional extension centers are twice as likely to be awarded an incentive payment and reach that meaningful use. You also see kind of in that pie graph there in this slide where our clients primarily are at, or how we're spread across the state. Clearly, the vast majority of our clients are in Southeast Michigan at about 50%, but we are scattered across the state and even up into the very, very snowy Upper Peninsula as well. All right, let's move on to meaningful use, kind of a brief overview of it. This is the slide I always like to start off with. It kind of puts the whole program into perspective. We get questions all the time about, what is meaningful use? Well, I like to represent it this way. Here we have sand, and here we have the meaningful use of sand. Let's all just take a moment on this very snowy Wednesday and picture ourselves on this warm, sandy beach. In the past, I've used this slide with snow and the seasonal, the meaningful use of snow with building a snowman, and I just couldn't do that to you guys on this wintry, snowy Wednesday. I thought we'd transport ourselves to a much warmer climate. So it's about taking your certified EHR technology, which is represented here by the sand, and demonstrating that you can meaningfully use it. So here it's represented by the sandcastle. In short, meaningful use is about taking your EHR and using it in a way that positively affects patient care. Taking it one step further, we're looking at the meaningful use as defined by CMS. Again, it's using your certified EHR technology to improve quality, safety, efficiency, and reduce health disparities, engaging patients and families. You hear a lot out there these days about patient engagement. Your EHR is the tool to use for that. There's, especially with this year with patient portals and whatnot, you've got a fantastic opportunity to really engage patients and families. It's about improving care coordination and population public health, and especially it's about maintaining the privacy and security of the patient health information. Can't stress that one enough. Ultimately, it's hoped that meaningful use compliance is going to result in better clinical outcomes, improved population health outcomes, increased transparency and efficiency, empowered individuals, that's that whole patient engagement arm again, and more robust research data on health systems. To achieve this complex goal, the criteria for meaningful use is staged in 3 steps over the course of the next several years. Many of you have probably seen this graphic or a version of this graphic. It gets used over and over again to kind of represent the 3 stages of meaningful use. So stage 1 kind of sets the baseline for electronic data capture and information sharing. It's really about kind of demonstrating that you've got particular components of your EHR are in use. And the idea behind the objectives and measures is to kind of get you used to kind of using the functionality that's inherently built into your EHR. Stage 2, which just started now in 2014, there are providers across the state that have gone to that next stage or are about to go to that next stage with a 2014 reporting period. Stage 2 looks to push the advanced clinical processes. So it builds on Stage 1, and in Stage 2, it not only raises the thresholds that we saw in Stage 1, but really takes it to that next step and is really about advancing those clinical processes, about really using your EHR in the way that it was designed to be used. And then in Stage 3, which won't launch until 2017, no one can start Stage 3 until then. Very little is known about Stage 3. They're still working on the final rule. We expect that to come out fairly soon. We're kind of chomping at the bit ourselves to get our hands on Stage 3 and get a better understanding of what that's going to be. But we do know that it's going to be about improved outcomes. Again, it builds from Stage 1 to Stage 2 to Stage 3. Everything you've done in the prior stages is built upon and amplified as you progress to that next stage. All right, enough on that. Let's get down to the meat of it and discuss the changes that have come to Stage 1 since the program launched a few years back. So in 2012, at the end of 2012, the Stage 2 final rules were released. And within the Stage 2 final rule were significant changes to Stage 1 as well. Really to get to where Stage 2 needed to be, it required some revamping and some rethinking of some of the Stage 1 objectives, and that's what we're discussing today. So the Stage 1 changes actually came to us through the Stage 2 final rule, and it wouldn't shock me at all if we have another round of this kind of thing when the Stage 3 final rules finally come out. I will no doubt make some changes to Stage 2 and possibly even Stage 1, but we'll see. First and foremost, I want to discuss the need to upgrade your EHR. Can't stress this one enough. I know there's a lot of confusion out there on this one about what stage you're in and what version of your EHR you can use. In 2014, every single EHR has to be upgraded to a newly certified 2014 version. Let me stress that. All of you have to upgrade in 2014. There are some vendors that already released their 2014 version even at the end of 2013, and some of you may have already made that upgrade. But if you have not upgraded your EHR and intend to participate in the Meaningful Use program in 2014, you must be on a newly certified version of your EHR. And the reason for that is along with when Stage 2 came out and these changes to Stage 1, it required additional programming be embedded into the EHR to meet these objectives and measures. So the product that you've been on that was certified by ONC back in 2011 or 2012, that carried you up through 2013. You were able to still use that version. But now that we've crossed into 2014, all of the EHRs, if they want to continue on the meaningful use path and be a certified product, had to go back and get new certification. So that list, which there used to be more than 3,000 products, 3,000 different EHRs that were certified, that number is a lot less right now. It's still growing. But there are only about 500 or so products that have been certified for 2014. So I do want to stress also that there's no such thing as being Stage 1 certified and Stage 2 certified within EHRs. There's only one certification that can be used now, and again, that is the 2014 certified version. If you have not already opened up discussions with your EHR vendor, or if you haven't already heard from them about their plans on when they will be releasing, or if they are going to be releasing a 2014 version, you need to get on the horn after this webinar and start those discussions. The timing of that release could really affect your ability to attest to meaningful use in 2014. So the sooner you get that information, the better prepared you will be for that upgrade and your subsequent reporting period in 2014. So because of this need to upgrade, because everybody has to upgrade to a new version, there's been a change in the Meaningful Use program that dictates that no matter where you're at, no matter what stage you're in or what year you're in within that stage, you only have to report on a 3-month or 90-day EHR reporting period in 2014. So several of you, if you possibly did a 90-day reporting period as in your first year, maybe in 2013, and you may have been prepared for that second year, which would have been a 365-day reporting period. But because of this need for everybody to upgrade to a new version, ONC has said, hey, you know what? 365 days it can't happen, because we have to give both the vendors and the doctors time to get that new technology implemented. And so because of that, everybody, no matter what stage, no matter what year you're in, only has to report on a 90-day period in 2014. Little caveats to that, though. If you are a Medicare eligible professional, so if you are in the Medicare program, and you're beyond your first year of meaningful use, you must select a 3-month reporting period that's fixed to a calendar quarter. And you must attest to these reporting periods no later than February 28th of 2015, so a little more than a year away. If you're a Medicare eligible professional in your first year, you can select any 90-day reporting period. It does not have to be tied to a calendar quarter. And if you're in the Medicaid program, you can, just like I just mentioned with the first year of Medicare, if you're in the Medicaid program, no matter what year you're in, you can select any 90-day reporting period that falls within the 2014 calendar year. So it's just those Medicare EPs that are beyond their first year. You have to make sure that your reporting period is tied to a calendar quarter. Okay, another change that came to us is regarding the exclusions. This is globally for all of the menu objectives. Prior to 2014, you could claim an exclusion on a menu objective and have that actually count towards one of the 5 required menu objectives. That has been done away with. You can no longer do that. So in 2014 and beyond, you can no longer select a menu objective and then claim an exclusion for it if there are other menu objectives that you can meet. So the goal here really is to become a meaningful user of your EHR technology, not a meaningful excluder. Computerized Provider Order Entry, CPOE. So these changes went into effect in 2013, but we're finding that many folks don't know about them yet. In 2013, CMS added an optional alternate measure to the objective for CPOE. So the original measure for CPOE was based on the number of unique patients with a medication in their medication list that was entered using CPOE. The new alternate measure is based on the total number of medication orders created during the EHR reporting period. So that means it's no longer necessarily about unique patients. So if during your reporting period you have a patient that comes in more than once, if you're entering CPOE on that same patient, you can count each one of those medication orders, let's say, whereas in the original measure it was about unique patients. So an EP may select either measure for this objective in stage 1 in order to achieve meaningful use. And note that this alternative measure is actually the standard. It's what is required in stage 2. So in stage 2, it kind of changes from that optional to this new alternative measure. Again, it becomes the standard. Another aspect of this change I want to address is the change definition of a licensed staff person for CPOE. Again, this started in 2013. But certified medical assistants can now also enter CPOE and have it count toward the denominator for this measure. This is definitely one area that is being audited. So it's vital that any CPOE you're using to meet meaningful use is being entered by the doctor, by a licensed nurse, or a certified medical assistant. In my experience, although I'm sure it's increasing dramatically as a result of this change to the program. But most of the MAs out there are not certified yet. And so if your MAs are not certified, they cannot enter any of the CPOE. If they are, they kind of, although it's not a licensure, certification is not licensure, it puts them into this bucket and allows them to also enter CPOE. I suggest that you get copies of your MA's certification and keep it with your printed meaningful use documentation in the event of an audit. This is something that they're definitely auditing. If you are audited, you will be asked to prove that all CPOE that was counted for meaningful use was entered by one of these licensed professionals. E-prescribing. So beginning in 2013, CMS added an additional exclusion to the objective for electronic prescribing for providers who are not for providers who are not within a 10-mile radius of a pharmacy that accepts electronic prescriptions. So before, you could only be excluded for meeting the measure if you wrote fewer than 100 prescriptions during the reporting period. They've now got this additional exclusion that was added back in 2013, which means that if you don't have your own pharmacy within your organization and there are no pharmacies that accept electronic prescriptions within 10 miles of your practice, you can also be excluded from this measure. Record and chart changes in vital signs. So the prior measure for this was more than 50% of all unique patients aged 2 and over seen by the EP have height, weight, and blood pressure recorded as structured data. That has now changed to a new measure where more than 50% of all unique patients seen by the eligible professional during the EHR reporting period have blood pressure for patients greater than 3 and height and weight for all ages recorded as structured data. So pretty big change there. I think most of this came from the pediatricians out there. So there's also new exclusions for this objective that have also changed. So the previous exclusions only allowed an EP to claim an exclusion if all 3 vital signs, height, weight, and blood pressure, were not relevant to their scope of practice, or if the EP saw no patients 2 years or older. However, under the new stage 1 changes, an EP can claim an exclusion if the EP sees no patients 3 years or older. EP would not have to report blood pressure. If all 3 vital signs are, again, not relevant to their scope of practice, EP would not record any vital signs. If height and weight are not relevant to their scope of practice, EP would still record blood pressure. Or if blood pressure is not relevant to their scope of practice, the EP would still record height and weight. So you got some choices there, depending on whether the vitals are not in your scope of practice, or if just blood pressure is, but not height and weight, or if just height and weight are relevant to you, but not blood pressure. You've got some choices there. You've got some options on what you need to report for meaningful use here. So this new measure and these new exclusions were actually optional in 2013, but they're now required in 2014 and beyond. Electronic copy of and electronic access to health information. So we've got 2 measures here that we're talking about simultaneously. One was a core measure previously, and the other was a menu measure. So in order to better align stage 1 objectives with the new 2014 capabilities, that 2014 upgrade I was talking about, CMS is replacing some of the stage 1 objectives. So these 2 that I've listed here, the providing electronic copies and electronic access to health information, with a single core objective to provide patients the ability to view, download, and transmit their health information online. The capability to provide patients online access to this information is a part of that that new 2014 certified EHR technology, and therefore the new stage 1 objectives with regard to this begin now, right now in 2014. So these 2 old objectives have now been combined into this new objective. So this is really a new stage 1 measure that has also worked its way into stage. This is really a new stage 2 measure that's worked its way into stage 1. Although only the first part of the new stage 2 measure is applicable to those of you in stage 1. So the way the new measure reads, so that combination of the 2 old measures into the new, is more than 50% of all unique patients are provided online access to their health information within 4 business days after the information is available to the EP. So it's about using patient portals. That's first and foremost the way that this is happening. And so any of the new EHRs, the new 2014 EHRs, all have the ability to either have a portal already embedded in them, or they have the ability to interface with a portal so you can get the data if you're going to use a third-party portal. But in the end, in 2014, you're going to need a patient portal because this is a new core requirement. When you transition to stage 2, there is an additional requirement for this measure. That means not only do you have to provide online access to health information for over half your patients, in stage 2, you're also going to have to make sure that more than 5% of your patients actually access this online health information that you've made available to them. But for now, in stage 1, you will need that portal up and running. You don't have to demonstrate that patients are actually using it, but you need to make sure that you get more than 50% of your unique patients signed up under that portal. All right, this next one has actually just been removed from stage 1. It's just gone. It's been deleted. That's the electronic exchange of key clinical information. So while the measure and objective it was attempting to drive were sound, worthwhile, and really an extraordinarily important aspect of our changing healthcare landscape, providers faced numerous challenges in understanding and meeting the requirements for this objective. As such, it has now been removed from the stage 1 requirements as of 2013, and CMS is moving instead to a more robust requirement for electronic health information exchange as part of the stage 2 objective for providing a summary of care record following a transition of care or referral. So this is this new measure that I just mentioned, the summary of care record for transitions of care or referrals. This is currently one of the menu objectives under stage 1. And it's going to become, it is a core objective in stage 2. For now, however, if you're in stage 1, you're off the hook and can choose to ignore this objective. Well, as long as you're attesting to 5 others, that is. Public health reporting objectives. So I want to stress that unless you qualify for exclusions for each of the public reporting objectives, you must select one of them as as one of your 5 menu objectives. So unless you can be excluded from either one of these, you've got to either do a test with MICR, or you have to do a test with the MSSS, which is the Michigan Syndromic Surveillance System. So beginning in 2013, all of the stage 1 public health objectives will require that providers perform at least one test of their certified EHR technology's capability to send data to public health agencies, except where prohibited. That was another clause that they added to stage 1, is that whole except where prohibited part. The intent of this modification is to encourage all EPs, eligible hospitals, and critical access hospitals to submit public health data, even when it's not required by state or local law. Therefore, if providers are authorized to submit the data, they should do so even if it is not required by either law or practice. If the test of submission is successful, which is the stage 2 requirement, the provider should institute regular ongoing reporting of this data. I mean, once it's up and running, you may as well be sending it on a regular basis. And in stage 2, this actually becomes the requirement. You have to move beyond just testing under MICR or under the Michigan Syndromic Surveillance and actually begin providing that data on a regular basis. But again, as part of the requirements, you must do either one of these unless you can claim an exclusion, and that is one of your 5 menu objectives. All right, so that is those gives you the changes that came to the core and menu objectives under stage 1. I'll talk a little bit about the clinical quality measures and the changes that happened here. So prior to 2014, you had to report on 6 out of a possible 44 CQMs. You had 3 core or alternate core that were kind of dictated for you, and then you were able to choose 3 additional ones out of the 44. So that's changed quite a bit. So there are now 64 CQMs available to you, and you have to report on 9 instead of 6, as was previously the case. So 9 out of 64. The ones that you select must also cover at least 3 of the 6 NQS domains, the National Quality Strategy domains, which I have listed here. Those 6 buckets are patient and family engagement, patient safety, care coordination, populations and public health, efficient use of healthcare resources, and clinical processes and effectiveness. So you got to make sure that when you're picking your 64 CQMs, that you're able to pick ones that are in at least 3 of these. And for some of you, you're going to be relegated to whatever your EHRs offer. There are definitely products out there that you can report on any of these 64, but you'll want to check with your EHR vendor and see what CQMs are available to you. It could be, for some of you, it's going to be a lot less than the 64, and you'll be kind of pigeonholed into reporting on whichever ones your EHR is able to report on. So additionally, prior to 2014, CQMs were actually one of the core objectives. It was core objective 10 before 2014. Now in 2014, it's no longer one of the core objectives, but it's still a program requirement. They found it was really just redundant for you to attest that you were going to submit your CQMs and then actually submit your CQMs. So a step in there that just didn't make sense. So they kind of stripped that away. And so while it's not one of the core measures, it's still one of the program requirements. So EPs in the Medicare EHR program who are beyond their first year of meaningful use will have to electronically submit their CQMs as opposed to submitting by way of attestation. So there's a module out there that you have to go to electronically submit your CQMs. If you're beyond your first year of meaningful use in the Medicare program. For Medicaid, it's a little bit different. EPs can choose to either submit electronically in 2014, or you can do it the way it was done last year by way of attestation. The electronic submitting of CQMs at the state level is launched now. It's there for you, but it's optional this year. In 2015, it will no longer be optional. So as of 2015, next year, everybody is going to be submitting their CQMs electronically, whether you're in the Medicare or Medicaid program. All right, so that kind of is the end of everything I wanted to touch on for the changes to stage 1. And I'm going to open up the lines, or not the lines, but I'm going to take a look at if any questions have come into us here. I have one question so far. All right, so clarification here. The question is CPOE by non-licensed certified staff. I realize that they do not count for meaningful use, but your comment was that no CPOE could be completed by non-licensed or certified staff, which is correct. Great point. I appreciate you bringing that up. To clarify, if you are intending any of that CPOE to count, if you're going to be counting that in your meaningful use measures, if it's going to end up in your calculations, in your numerators and denominators, those ones have to be entered by a licensed or certified staff. But certainly, if you've got so much CPOE going in that you don't need to count all of it, certainly those ones can be entered by non-certified or non-licensed staff. You know, the intent of this of dictating that it be licensed staff is that CMS believes those people are the ones that if during the order entry there is some sort of issue, it's the licensed and certified folks that have the education or the experience to be able to recognize when there's a problem and make any changes. But certainly, I appreciate the clarification that if you do not intend or do not need that CPOE to count in your meaningful use measure, you can have a non-licensed or non-certified staff member enter that. So appreciate you bringing that up for clarification in case that confused any of you. Give a few moments here for any additional questions. I don't see anything as of yet. Another question just came in. If we have any further questions in the near future, can we contact you? Absolutely. Right up now on the slide that you're seeing has my personal contact information, my email address, as well as phone number that rings right to my desk. You also have the general MCEDA phone number and the general MCEDA email address. Please, if you have any questions, we can help you with, whether it's specific to the Meaningful Use program or to the services that we provide. Reach out to us. We'd be happy to engage you and answer any questions that you may have. While we wait for any other questions to come in, I want to point out that our next webinar is coming up 1 month from now. We are scheduling these for the first Wednesday of every month, so the next one that comes in is on March 5th, and that is again at noon. And we'll be discussing we've invited our very own Chris Calderon to speak about our process improvement or our TPO service that we have. He'll be talking about practice efficiencies and how to increase and be as efficient as possible in your practice. So it should be a very engaging webinar, and I invite you all, if you haven't already, to please sign up for that one as well. There's information on our website at the MCEDA website where you can both get information on the next webinar as well as sign up for it. I don't see any other questions coming in at this time. So with that, we will wrap up. Again, if you have any questions that you think of after the broadcast is over, just reach out to us. We'd be happy to help you. So I want to thank you all for attending this month's MCEDA webinar, and I look forward to seeing you all on our future webinars. Thank you.